We have new guidelines also just released at the EASD meeting in Europe that are led by the ADA and the EASD that have a major change in how we approach patients, where it becomes less glucose-centric but incorporates more the patient characteristics in selecting therapies. And in particular, patients with atherosclerotic cardiovascular disease, or ASCVD, they have seen benefit with two classes of drug, the SGLT2 inhibitors and the GLP-1 receptor agonists. And the evidence base has been growing on all of those different aspects, and some even here, other recent announcements. So quite amazingly, with the SGLT2s, there have been already 2 trials. There are a third one presented here that'll show benefit of dapagliflozin in the DocWire trial. But with the GLP-1 receptor agonist, the LEADER trial was the big news. Since then, there have been 4 more trials, so it's now 5 out of 6 trials show a cardiovascular benefit when adding a GLP-1 receptor agonist on top of standard of care. And the most recent trial is the REWIND trial, where they noted that only a third of patients had atherosclerotic cardiovascular disease, and so 2/3 were primary prevention, and yet adding, in that study, dulaglutide, there was benefit of cardiovascular reduction in events. So this looks like a big class effect of the GLP-1 receptor agonist, and the SGLT2s also have had a very consistent benefit. So we're reorienting our therapies to trying to prioritize those therapies that have proven benefit and then tailor to the patient characteristics. And so other factors that are in this guideline of looking at whether a patient has chronic kidney disease, heart failure, at risk of heart failure, obesity is another factor. And so we can start choosing and prioritizing those important classes as a way to really optimize diabetes management. So very exciting time in managing those patients, and we as cardiologists are trying to engage with endocrinologists and primary care to do it together and get optimal treatment for our patients. Well, the management of diabetes is a tricky one, and this is something that the primary care physicians do usually, and then for more complicated patients, endocrinologists often will be asked to be involved. And we as cardiologists have not been involved. We really say follow up with your primary care doctor. But now, with all of the cardiovascular benefits, we have to engage. And so we're sort of trying to figure out how to communicate. We don't want to step on their toes, and yet we want to break down any inertia to choosing these classes of drugs with cardiovascular benefit. And so it's something where probably just talking together is the key, and communicating and working together. Ultimately, we both will be managing patients and should. So it's a key step to create more links between our care of the patient with regard to diabetes and cardiology.